Well, good evening. Lovely to see all of you here. I'm Ilona Kickbusch. I'm the director of the Global Health Program here at the Graduate Institute. And what is happening here over the next hour is what we call In Conversation With. We invite a distinguished, interesting person to have a conversation. So no PowerPoints, no lectures. And the format is that I ask a couple of questions for about half an hour, and then we hand over to you so you can ask your questions and get responses. And I really hope that we can have a very, very special conversation here. It's my great pleasure today to have such an interesting person with tremendous achievements, Atul Gawande. And I wonder, have any of you read any of his books? Yes, look, yeah. In German, we would say Fangemeinde. So these are the people that really respect you and like your work. So, of course, many of you will know who Atul is and everything he's achieved. He's a kind of 21st century Renaissance man. He manages to stay a practicing medical person. He's a professor at Harvard. He's a distinguished writer. He's a lecturer. And he has initiated, a whole lot of really hands-on projects, both at the national level in the sense of in the United States, but particularly globally. And I was really intrigued when I was researching for today. I was also then sort of saying, oops, how am I going to manage this conversation? I went on YouTube and I watched the conversations with Charlie Rose and people like that, and I said, oh dear. But I'll try my best, and as I said to Atul a minute ago, I said, at least, I don't have a Me Too problem like Charlie Rose has now, so maybe that speaks in my favor. So actually, Atul, the first question...
That and you actually know more about the subject, so that helps too.
So I thought the first question I'd like to ask you is to help me understand a sentence I found that it seems you have said. And it seems you said at one stage, I'm very interested in failure. And I think that has a lot to do with the work that you have built up over the last decades. So explain that sentence to us. What does that mean to be interested in failure? And do you think other people should be interested in failure? Everybody reads these books about success and all of that. So why be interested in failure?
Yeah, I mean, I can give you the intellectual answer. And the intellectual answer is, look, if there's a bell curve of distribution about how people perform, it's a lot more work to figure out how to get people up to the top 10% performance than it is to figure out how to get rid of the bottom 10% of performance. On the other hand, there's also the personal reason, which is I started with writing, with learning about public health, and in my surgical training, all at the same time. And my perspective was really driven by being an individual who's going into a field like surgery, but it's typical, I think, of any of our fields across medicine and in public health, that the volume of knowledge is exploding faster than I could keep up with. The skills required to be able to do a good job in the field seemed to be well beyond where I was. And then you had to learn by, you'd learn, people would basically tell you, well, this is what you have to learn, and they describe it in great detail, and it seemed impossible. It didn't seem feasible, like this is how you run a randomized trial in 50 cities, or this is how you do a pancreatic operation. And it seemed so far away from where I was standing as a trainee that I didn't understand how to get there. And the easiest way I could think of is like, how do I just not do the stupid stuff? Like, can I just at least not do that? And that turned out to be a kind of winning strategy. That basically, could I learn how to get rid of the worst mistakes? And I was interested in the most basic kinds of failure. You know, in the beginning, it's all about how do you even tolerate the learning curve? You know, doing your first of anything involves you being kind of crappy. And figuring out how we have systems that allow people to learn, allow organizations to learn, allow systems to advance. It happens at the micro level, but also at the macro level. And then not make the same mistakes over and over again. How is it possible that we now can teach 8th graders mathematical concepts that required Euclid to understand in millennia past? And so we have somehow been able to advance over time, and that's what got me interested in failure and then the systems that seem to protect against failure.
So tell us more about how do you get a system to change, because I think that's been another thread of your thinking and your work. What are those factors where you felt from your experience, if one approaches it that way, one gets a systematic change? Or, you know, you can also approach it from the other side, when you give up and say, you know, this system is just not going to change, ever. Some of us feel like that about the medical system, but maybe you can comment on that.
So that's a longer answer, but I'll try to start in a fairly simple place. The first question I had, so I'm going into surgery, and I was very interested in the question, okay, if I'm going to make a difference in this field, in surgery, how would I go about it? Where should I put my energy? And I got to be part of a study looking at error in hospitals in Utah and Colorado, 2 states in the West in the United States. And we had 15,000 patient records that were from 28 different hospitals. And what we were looking for were all of the cases where the patient had a death or a disability as a consequence, as the outcome of their care. And the first question that I wanted to ask was how many of them were surgical and how many were not? And it turned out that 2/3 were surgical, that there was, and it wasn't that the surgical cases were higher risk than medical cases, it's just that we do a lot of surgery in hospitals in general. That's a large volume of what they do. So then the second question was, of the deaths in surgery, how many were because of failure? How much were because of ignorance? The knowledge did not exist. They had a heart attack, we don't know why. Or they had infections, and infections happen, we don't know why. Or XYZ. And how much was because the knowledge existed, but an individual or the organization failed to execute on it? And in that original study, just using the medical records, we found it was the vast majority were lack of execution. That was really interesting to me. And we subsequently I did some further work where we did interview studies with people around root cause analyses, and we did malpractice record studies where you get the whole deposition from what happens in different kinds of cases. And basically, I came to the conclusion that at least 3/4 of the major death and disability that occurred in surgical care was due to lack of execution, which meant focusing on those would be a winning way to go about how to make a difference. A couple more things to pull out about that. Number one was understanding why deaths from lack of execution or major disability from lack of execution required kind of going through and really classifying and simplifying and understanding what the nature of that was. But it was also just at a philosophical level, it seemed to me really fundamental and really interesting because, you know, as I read the history of medicine, it was all about overcoming ignorance. The whole of human history has been that we have lived as beings in a space where diseases were not well understood. And then by the beginning of the 20th century, we were starting to classify how many diseases there were. Now we have been able to classify 70,000 different diseases because you have the ICD-10 from the WHO, and you can look at all the coding categories. And we now know 13 organ systems, 70,000 ways that the human body fails. And then the second half of the 20th century, we discovered 6,000 drugs, 4,000 medical and surgical capabilities, a variety, actually an uncounted number, but you know the 9-volume DCP-3 has them, of hundreds of ways to prevent disease, and we are trying to deploy that capability town by town to everybody alive. And that is a powerfully different place that our current generation lives in, which is where the problem of lack of execution across multiple fields is at least as big as the problem of ignorance. And so understanding systems...
It's really scary also if I think, as a patient now and a little bit involved in the AMR discussion, that, here are intricate systems, here are people that are incredibly educated, and in the end you find out they don't wash their hands.
That's right. So this is where it gets, the second level of interesting enters. So how do we deal as systems with this? So what we haven't done is applied science to that problem. We solved problems of ignorance with lab science, so what would it mean to apply science here? Well, as we started pulling apart what was happening and classifying what was going on, you realize our major strategy in medicine and in public health has been, well, let's teach people what the right thing to do is. Let's teach, you should be washing your hands. And, we should be delivering babies in the following ways, and we should be, in order to reduce the likelihood that babies die at birth, and we should be giving the following drugs and so on. And then the consequence is that you spend more and more and more years learning how to enter into these fields until now you're 40 years old until you even get to start. And then you come out and you have the smartest, hardest working people training the absolute longest, and they come out, and those are the results it gives you: a 3% death or disability rate, and also a very wide, more than 300% variation in the differences in the outcomes in any given country, and then between countries even massively more. We just finished our trial in the north of India in childbirth, where we found that the hand washing rate, the discovery that hand washing matters in childbirth and prevents childbed fever, goes back to the mid-1800s in Semmelweis, and it was 0.6% in the baseline in the places where we were. So, our notion that, well, let's train is giving us the results that we are currently getting. So then we get to the stage 2. So we said, okay, we're going to train you that you should do X. Now we're going to say you must do X. So now we start implementing policies that, we will sue you. We'll have a malpractice litigation regime. We will have licensing regime. We'll pull away your licensing. We'll have guidelines and regulations. And if we're feeling nice about it, we might do a pay-for-performance program. And what we find with those kinds of approaches is that they do work. They are, but they're very expensive, and they only get marginal results, and they decay with time. People learn to game whatever measures you put in place for pay-for-performance programs or regulated programs. So the third level that you come to is where you systematize it. And this is where the writing part of my life dovetails with the public health part of writing. A lot of the ideas that I've learned came from exploring it in writing. So I was a third-year surgery resident. We'd completed this study, and I wanted to understand, what does it mean to be systematic and to bring science to how do you engineer better results? How do you systematize that something like hand washing would happen? And I found the example of anesthesia, which had committed at a stage where the average anesthetic risk was, from a general anesthesia in the 1970s, about 1 in 3,000 to 5,000 people would die from the general anesthetic. And we used to say, as surgeons, the risk isn't my operation, the risk is really the anesthesia. And as if that's just, the way things had to be. And there was a guy named G. Pierce and others, but he was the head of the American Society of Anesthesiology, who said, we're going to, he'd had a death of a healthy 18-year-old from having the tube go down the wrong way into the esophagus, and had been so devastated by his responsibility that and he became president of the society, that he said, we're going to focus on patient safety and engineering solutions. And they found basic solutions like making it so there was a monitor on the tube that could pick up that you're not getting CO2 back, indicating that the tube's in the wrong place. Making it so that you couldn't, in those days you could turn the oxygen level down all the way to 0. Like, nobody needs 0 oxygen, so they made it so you couldn't turn it below 21%. They made it so you couldn't plug the anesthesia gas line into the oxygen line and get them confused. A variety of steps in the way. And so you could yell at people all you want. Don't do this, don't do that. But when the rates of error of any individual error are low, but you're doing very complex things, you start creating systems. And those systems can range from forcing functions, defaults, feedback loops. And the simplest system that I'd come across were checklists.
I'm really intrigued with what you say, because in a way it's an, quotes, environmental systemic intervention rather than blaming individuals. And you're doing that in a very complex medical environment, surgery. And it's intriguing for me, coming from the area of health promotion, where actually a very similar thing happens, that, for years people say, you should do this, you should do that, and don't eat this, and don't drink that, and whatever. And meanwhile, your whole environment is structured in a way that, drink, eat, don't walk. So do you see a similarity there as well, that in many, many cases in health and in medicine, an intervention in the more systemic part around people, either professionals, individuals, patients, actually makes the larger difference?
Completely. What you're dealing with is the reality of human vulnerability and frailty, that we have a limited capacity for memory, we have limited rationality, we have limited stamina and ability to tolerate stress in different situations. And so, around health promotion, for example, there was over 20 years of focusing on smoking cessation. Like, it's a sign of weakness that you can't kick nicotine, which is even more addictive than heroin. And we had to make the commitment that, it's tobacco control, that we have to get rid of tobacco. And that then the whole public health movement of discovering, here is our checklist of what we build in as the steps. You have to tax the heck out of it. You have to enforce underage smoking bans. You have to remove it from public establishments and have a public information campaign. And the combination of the four replicably drops rates by more than 50%. And now you have methods that you can begin driving outward. I learned a lot, actually, in my public health courses about taking that system point of view. It really originated, I'd gotten my master's in public health and was working my way through. I did the master's in public health because the real reason was because people told me, if you're in surgery and you're doing this kind of stuff, it's just too hard to explain, so just get a degree in it, in public health. I'd worked in politics, so you should have a degree so you're actually hireable afterwards. But then when I was doing the math, I was like, I got to get something out of it. So I wanted to learn statistical techniques and how to run trials. But the philosophical approach of population health and recognizing that action required more than education and that you needed to have environmental interventions that were really systems interventions and you took into account human factors, was very fundamental to saying, hey, if we have taken those public health ideas and then brought it to childbirth and said, childbirth with 150 million deliveries per year should be understood as a public health system, and that everything from the prenatal care to the aftercare could be done in systematic ways that were better. Here we were quantifying that you had 300 million operations worldwide, double the number of childbirths. That here was that was necessary for emergency obstetrics and necessary for people living a long and healthy life across the lifespan, and was being done with death rates 10 to 100 times higher than in childbirth in any given country. That this was an opportunity to take the public health view and engineering view and begin to look at it and apply very simple, trying to make it as simple as possible, systematic, scalable approaches in that same way.
Yeah, I was struck by another similarity, and that is, the whole field of behavioral economy and Cass Sunstein's work, and sort of nudging people to do the right thing. And again, I was intrigued that one usually looks at it in terms of nudging citizens or patients, etc. But what I found intriguing, that your work with the checklists, etc., actually nudges some of the most highly trained, high-level professionals that we have in our societies. So have you had conversations with Cass about this? And are you expecting the Nobel Prize as well?
Why? Yes, we've had conversations. One of the challenges that I have with the conversations with the behavioral economists is that many times the nudge doesn't scale. So the nudge that you can build into an electronic system in a institution, for example, they've shown over and over that if you list medications that are available to the physicians and you naturally list the generic medications as the first default in the electronic systems, then you get vastly more use of the generics. You allow them to opt out and to change it to the brand name, but if you do that, you lower the cost substantially. Now, scaling that with all the different kinds of electronic systems that there are is, I don't know how to take it to scale. It is eventually scalable once you solve the problem of interoperability, but until we do, I sort of, it doesn't feel like a viable solution. So, when we were taking on the surgical work, we sometimes could use nudged approaches. One of the first problem that I took on as a resident was the most common lawsuit in surgery and the most kind of consistent, reliable failure that happens across the world is that we leave sponges in people after surgery. And it occurs again and again. It's a rate of kind of 1 in 1,500 to 1 in 3,000 operations. And our system for doing that is the nurse counts everything at the beginning of the operation twice. 2 nurses count everything twice, and then they count everything twice at the end. It's actually stunning that with 50 to 100 sponges, that the rate is only 1 in 1,500 failures. Because like if you count a deck of cards, the number of times you come out with 51 cards or 53 cards, just think about that. And that, is under stress in the operating room. And in fact, we found, it was my first New England Journal article, we used the approach of a case control study from public health and applied it to an error. So we took people who had sponges left inside them in 60 different institutions and matched them to 4 people who didn't have sponges left inside them, having the same operation in the same institution in the same time period. And what we found was there was a 900% increase in risk if it was an emergency procedure. And now you understand, under stressful situations, those systems break down, and it's an inherently flawed, it's an imperfect system. And so we then tried various nudges, ways of having you could make it so that the sponges have to be put in bags that are done in tens, so you could visually see that one is missing, and unless you've separated them out, then it's easier to see that. And that is an effective way, but it still doesn't get the numbers down, so we just created an automated system. And so it was barcoded sponge scanning. Sponges are only a penny a sponge, so you have to have a way that's as cheap as that. It's, by the way, just in the US, $150 million industry buying sponges, and a $500 million industry for settling the lawsuits around sponges. So we figured we could price something at an extra penny per sponge, and that's what a barcode costs. And if you scan ahead and scan at the end, it eliminates the problem.
So did you get some problems with the legal profession after this?
Oh no, we were thrilled. Yeah, so our malpractice insurer, there was 19% of lawsuits for surgeons disappeared, and so they actually pay institutions to adopt it, and yet we're still only at 20% adoption, which is another question. We'll get to implementation as we talk about this.
So so I wanted to get to the title that we chose here, From Paper to Policy in 10 Years, and when I was discussing with Atul before we came down here, he said, well, the really interesting thing was moving from policy to implementation.
To practice, yeah.
To the practice of it all. So share some of those those steps along the way with us. So, you know, you've created this thing, you've got people to adopt it as a really good idea, and then what?
Well, so you had to be thinking about the practice even before we created the solution. So the background is that the WHO in 2007 launched the WHO Patient Safety Program and picked as one of their lead campaigns to reduce deaths in surgery, asked me and my team if we would write the guidelines around safe surgical care. And I agreed to do it, but only if we could also implement the guidelines and test their implementation somewhere, because there are a lot of guidelines that get put out, but you don't have a chance to actually see if it can be implemented. And I didn't know how to implement the guidelines. I didn't care if we made 10 things that we recommended, let's just implement one of them, but let's figure out if we can make a way to do that. Then, as we are building the guidelines, we gathered all of the major organizations around the table. I see WFSA here, the World Federation of Societies of Anesthesia. We had the regulators from the National Health Service in England to the EU folks, to the ones for America and Canada and elsewhere. We had the experts, and we had patients in the room, including a man from Kenya whose daughter died from lack of oxygen on the operating table, and wanted to see that this would never happen again. There's nothing like the force of a patient in the room who, when people say, that's too hard, let's drop it, and he just, all he had to do, I just turn to him and he'd go, why?
Any patients in the room?
All of you are patients in the room, right?
I was going to say that. Thank you.
But someone whose daughter had died, he just has to say why, and then people double down. So but if we tried to go for consensus, disaster. So the guidelines were by consensus about what they would be done. But how to implement it, we ultimately zeroed in on trying to use a checklist to get all 10 guidelines operationalized in an operating theater. Worked with an engineer to engineer it to be as short as possible and fit into the workflow as a practical thing that could be used very widely. You know, a piece of paper that could be blown up and be a poster on the wall with a communication meant to drive communications at a flatter hierarchy. So everybody speaks up, the nurse, the surgeon, even the medical student in the room, to introduce themselves, say what role they have, name concerns or their plans for the patient, and ensure everybody's on the same page. We did not ask that all of those organizations agree on the content, and they didn't all agree on the content. But they all agreed to tell us what they were unhappy with about the content so that we could address their issues as best we can. So it was like designing a drug. You don't design a drug by committee, but you want to know every concern that everybody can raise and then do your best to incorporate it and explain why you have done that. So the result was, and then we said, and then we're going to do an experiment, and we want you all to join us in the experiment. And we did it in 8 cities around the world with many of these leaders. And it was from Ifakara, Tanzania, Rural District Hospital, to Seattle, Washington, from London to Delhi. And across 8 hospitals with 8,000 patients, every hospital had a reduction in complications. The average reduction was 35%. The reduction in deaths was 47%. I said that, you know, it went from paper to policy. So the paper was published in I forget the date, but it was on a date in January 2009. And the very next day, the National Health Service announced that they would be requiring it and implementing it in the entire English NHS. And then within a week after that, the Scots came on board, the Welsh came on board, the Irish didn't want to be left out, so the Irish came on board, then Spain came on board, and then you had a natural experiment in beginning to roll it out. It was crucial that you had built them in to be part of the experiment in the first place. And that took effort and it took time, but it was worth that effort. The second thing that happened, though, is as the natural experiment rolled out, we knew it was not going to be implemented well. And knowing it's not going to be implemented well, it could kill the whole policy if, you know, it's mandated, forced down people's throats, they don't use it, and then you say, and that's exactly what happened. So in Canada, it was implemented as a regulation. and then 1 year later, or sorry, 3 months after every hospital had certified, under penalty of being out of compliance with regulations that would have cost them reimbursement, that they were implementing it. 3 months later, the death rates were measured, 0% improvement in death. But we knew that that would be a concern, and so we began working on what were the kinds of approaches to implementation you could use. And so in the state of South Carolina, this was a conservative state, so they would not regulate it. We created a collaborative, so voluntary collaborative. All of the CEOs signed up to come on board. And we essentially used a social network approach of every hospital. We developed champions. We did some training of the champions. They did a step-by-step rollout. I can tell you about it if you're interested, of what you do with those teams over a period of 19 weeks. And then the result there was the hospitals so 1/4 of the hospitals completed the implementation. So you didn't get full implementation. But those hospitals had a 22% reduction in mortality compared to the partial or incomplete completers. Scotland, we partnered with, did both. So they took the approach of the bottom-up support led by their quality group and held hands as the hospitals went through their implementation, worked with them to figure out what do you do when the surgeons yell at you, saying, you know, what's this stupid thing? But also mandated it as policy. And after 3 years, they got to 100% coverage. And their 3-year results were a 27% reduction in mortality across Scotland, 10,000 lives saved. And we've seen every experiment in between. We're now completing a 5-year evaluation of Scotland, which we've just sent for publication, which will be interesting for you to see. So we've had everything from the 0 success to with mandate only. We've had voluntary approaches with early adopter success. We've had pay-for-performance programs, which interestingly didn't have much better results in the pay-for-performance program, slightly better than just mandating, but not obviously better. And then the combination approach where we've had very strong success.
So last question from my side before I hand over to the audience. Of course, now this whole issue of safe surgery has become an issue of global health. And that in itself is an innovation because, of course, you know, in the old days, we had these pyramids with tertiary healthcare, which in everybody's mind was surgery right up there. And before that, we do everything else, you know, primary healthcare systems, et cetera, et cetera. So something is changing radically in how we see surgery, how we see the health systems develop in low and middle income countries, et cetera. So could you say a little bit about that initiative and what it means? And then we'll hand over to the audience and they can pick which parts of your work they want to ask questions on.
Yeah. So I think what's happening with global surgery is also reflective of an even bigger dynamic that goes beyond surgery that I think is a really big deal, and it's been part of what we've emphasized in different kinds of announcements that I've been part of this week. Most of public health has really been focused on disease-based verticals, as many of you have thought about and talked about, and we've always desired that we really should be looking at system level instead of, you know, HIV or TB control or malaria control or opioid overdose or those kinds of things, that we really should be talking about the horizontals of the primary healthcare setting, the labor and delivery, the pharmacy distribution, the diagnostics, and by the way, the surgical care. Now, the surgery has usually been regarded as a kind of luxury, as you say, kind of this tertiary level, but I've been part of the DCP3, the Disease Control Priorities Initiative with the World Bank and the Gates Foundation. And about every 10 years now, this is the third 10-year version, they've evaluated every public health intervention that there is. And in this year, they took a systems approach and defined packages in universal health care. And for the surgery volume, we defined 44 essential and emergency surgical and anesthesia care procedures that are that a first referral hospital, we said, should be able to provide. They included 3 procedures, the bellwether procedures we called them: cesarean section, trauma fracture repair, and laparotomy, which could be for anything from a typhoid perforation to an appendicitis to a ovarian tumor. And for the 44 essential emergency surgical practices, investing in the capability of a first referral hospital to have that, which had once been regarded as, that's Apex, that's delayed, you don't need that till later, it's a luxury, was just as cost effective as childhood vaccination. So understanding that for the sake of people's long-term health and disability, you can't solve the problems in maternal and child health, you can't solve the problems in trauma, you can't solve the problems of major disability across people's lives if you ignore that basic system. One of the critical things I think that has happened this week is making that practical, because these feel so abstract as to feel something like you can't tackle. And in surgery, there were several things that have come out this week. First of all, WHO and the World Federation of Societies of Anesthesia have advanced the guidelines that we wrote 10 years ago to update the anesthesia guidelines and how to drive in further progress along the way. And I think that set of work is really critical, because we have shown that you can scale improvements in system level care with basic systems like a checklist and implementing them. I mean, at this point, we now know we're past at least 100 million of the world's 300 million operations are now done with our approach and effectively, and showing that we're effectively saving lives in populations. That was from a study in 2009 to less than a decade later that we've gotten that far. So I think it's making real the quality improvement that you get to. Now, the second part is around being able to make tractable the access and delivery side of it. And there's a group led by John Mira, who I think I see here, and the PGSSC. I never remember what you guys stand for, but it's a great program where they've defined the National Surgical Obstetric and Anesthesia planning process that countries can go through. So instead of having a planning process around HIV and around TB, to have a national surgical obstetric and anesthesia plan. And you have the first countries now, and so just last night we had an event with the Minister of Health, the Principal Secretary for Health for Tanzania, which was one of the first countries that have laid out their plan. So they've done an assessment of where are their gaps in their coverage, who has access to C-section, who doesn't have access to C-section, and then how they would step by step build out their access and capacity, finance it, and what the costing would be, and then start approaching donors and looking at their own health system priorities, begin to provide access to that care. Tonight is a dinner and another event around the other component of this, which is having similar plans around your primary health care system. I'm on the steering committee of a WHO, World Bank, Gates Foundation effort called the Primary Healthcare Performance Initiative, which is also defining what are the components that policymakers use to just monitor, first of all, know what the state of your primary healthcare system is, where its gaps and weaknesses are, and then have plans that become improvement strategies that you invest in along the way. And you simply cannot do all the things on the list of public health goals, which range from Ebola response to prenatal care to managing TB, hypertension, diabetes, and other NCDs. You're not going to be able to do it without the basic system strengthening taking place over time.
Thank you. Over to you. Who would like to ask a question, comment, have a conversation?
I see one back.
All right, back there. There's a mic coming, please.
Thank you for that just excellent expose. Since everyone here is an advocate for global surgery, I wonder if you would be so kind as to distill what you said tonight and what you know into an elevator pitch for all of us should we be able to meet with a minister of health or a member of parliament or our Senate or National Assembly, the 1-minute elevator pitch that says exactly what you just said, meaning condense it down into surgery is not, what is the proof that surgery is no longer to be considered a luxury and as valuable as vaccination?
Well, so what I tell people is straightforwardly, that in order to live a long and healthy life, it is inescapable that you require a sound surgery system, because in low-income countries it starts with almost half of the surgeries emergency obstetrics, and then you need trauma care, and then you also need some basic hernia and other kinds of care. And they get it very quickly. They themselves have required surgery and are going to require surgery again. And all lives have equal worth, and we want to make it. Where they stall on that elevator, like, that's fine, I really care, see you later, is how do you make it happen? And I think what you have to tell them is that we know how to make it happen. And number one is we have seen, whether it's in the United States with the Medicaid program for the poor, South Korea, which passed its universal health care coverage program when it was only at $4,000 GDP per capita in 1977, that they passed their program. Or you have today at $1,500 GDP per capita, the RSBY program in India, that those are enormously successful within a decade in increasing people's access to the procedures that they need. And by the way, also dramatically increases the workforce that comes to bear. People worry about whether there's going to be enough schools and enough trainees and enough. Once the demand and the ability to finance it is there in every one of these countries, the problem quickly becomes, are we doing too much surgery and what's the quality? South Korea, the big problem is overproduction of surgery. In India now, with the RSBY program, people getting access to private sector care, and they're getting 75% C-section rates when they're going into the private sector. So now, safety and quality is that's the thing that I worry about the most, because the backlash when it's done badly and wrong. So we have to be the advocates for the financing of a sound surgical system and access to care, and then professionally policing, measuring, and driving the solutions that ensure that the safety and appropriateness of the care is there as well.
Thank you, and we're now on the 85th floor. Here you are.
I gave them the whole plan and the pitch.
So where's the mic? This gentleman here, please.
Hi, hello.
That's why I write for the New Yorker, though, because they give me 10,000 words. That's great.
Hi, hello. I'm an internal medicine resident here in Geneva. So my question is, now that we pass from the Minister of Health to the institutional level, what, in your opinion, the nudges that we can give to health professionals to achieve this cultural change that is needed to implement these tools? So how do we get, using your metaphor, from cowboys to pit crews?
Yeah, so the single most difficult thing I found about going into practice, and then also thinking about how public health and the health system integrate, is the recognition that volume of delivery, the 6,000 drugs and 4,000 medical procedures and surgical procedures, and the hundreds and hundreds of preventive approaches that we have, in order to do our jobs as public health professionals or healthcare professionals, the volume of knowledge and skill exceeds the capability of any one of us to execute on it anymore. We all only have a piece of the delivery. And so that means we're all saddled in being largely trained in systems that have hired, rewarded, and trained us to be cowboys, to be the solo actors, when what the world really needs are the pit crews, people who know how to be effective with groups of people, often separated in time and over space. And I think a lot of the skills in public health are very well suited to understanding what's needed, because public health has a few basic things it emphasizes. Number one is measurement. So why is measurement so important? If you are only a piece of care, you cannot see the end result unless someone is actually measuring and surveilling. Oh, the polio was eradicated or not eradicated. Oh, the baby lived or didn't live. Oh, the patient is walking again or not walking again. And so what's the function of the system? And by the way, what did it cost to get there and how much waste went into that process along the way and how much harm was done? So, you know, that fundamental public health surveillance mentality that goes back to, you know, the Broad Street pump is a crucial set of skills that we don't teach. The second is how to teach cooperation. That living and working in a world where autonomy of the clinician has been one of the highest values that we build our systems around is a failed system. And instead, it has to be built around the capability of the group of people. There is a need for autonomy in the form of ingenuity and bringing new ideas to the table and actually being able to experiment and bring them to the table. But then you need the capacity of groups of people to pick among themselves, to defer some authority to others, to pick the best ideas, and then go along with it and see all of our work as a continual experiment the whole while. And engendering that means having skills of how do you lead groups of people to work through conflict and work through differences of opinion about which ways to go, and how do you also serve as a team member and let others lead some of the time. And we don't have that implemented as our way of doing things. Our levels of capability as organizations in the high-income world or in the low-income world are very low. We don't know how to hire people. We don't know how to deal with conflict. We don't know how to set goals, measure against those goals, and then standardize as we try new things, keep standardizing and experimenting and standardizing and experimenting. You know, we've done measures across now 10 countries. I've done with a group called the World Management Survey. And looking at hospitals across the world, the variation there is significant variation from country to country. The US's management strength is somewhat higher than Britain's management strength, which is somewhat higher than Italy's. Italy's was the lowest of 10 countries we had. But the variation within the country was massive. You had places that didn't have any of the simple management capabilities and ability to have any of those things I described, to ones that were pretty good at it. None were 5 out of 5 on their scores. We are well below where manufacturing and retail is in our ability to do our work. And the only thing we have going for us is that we're at least better than the schools. Schools are even worse at being able to work their way through how to address performance at population level.
Back there, yes, the lady here.
Thank you, Dr. Gawande. I've heard you before, so I'm quite aware, and I'm a good fan to read all your books.
Thank you.
My question here is to see on the checklist that you have for global surgery, does it include the post-surgery examinations or control?
No.
Which in particular, I mean the recovery room, yeah. And few days after, let's say you've got a big cut and you have infection, where does the global surgery come into this?
So when we started the program, we started by saying, okay, let's start where the highest risk is and where you could catch the highest risks. And the operating room we found was where you could catch and address in a key moment in time about 75% of the major preventable errors. So you had this leverage point where right up until the moment of incision, if things weren't done right in the pre-planning, you could catch many of the issues. And then you could make a plan before you left the operating room for what's going to happen in the next 24 hours. But Tom Weiser's here. Where's Tom? Raise your hand. Tom is a researcher who's also part of our Lifebox board. Lifebox is working in middle and low-income countries to implement solutions for safer surgery. And he's the lead of the Clean Cut program, which is about bringing not just safe anesthesia components of the checklist, but the infection reduction components. And the challenge is exactly what you're talking about. Infection doesn't appear until often a week or more later after surgery. The patients are long gone. And so the next stage of building system solutions and tools will require, number one, what are the highest risks and the highest opportunities to address in recovery in the first day or so when people are still within the system, within the hospital. But then how do you have a connection to community health workers who then can follow up, can know the patient is after surgery, can follow up and know how to recognize infection, know how to bring them to a local center. Often they've gone very far away in the low income settings. So you want places that can have the first steps of being able to treat infection or bring them back to the original facility. Because the death rates, so infection in the lower income areas is the number one cause of death in the surgical patient. So this is still like the 19th century where infection was the greatest source of morbidity and mortality. When you get when infection under control, bleeding-related issues are often the more deep concerns, and teamwork-related issues. But infection control requires us building those systems for that next level. So we want to work on that, but it's again, anybody who wants to partner, bring some resources, we're happy to work on the next level of this.
Okay, there's a very motivated gentleman just there.
Thank you very much. That was very nice.
Thank you.
I'm Moody Qureshi. I'm a neurosurgeon working in Kenya. And over the last 2 decades, I've kind of developed a reputation that I'm the mobile outreach neurosurgeon because I ended up operating in Kenya, Uganda, Tanzania, Zanzibar, Zimbabwe, Sudan, Khartoum. And everywhere that I've gone, because I work at the Aga Khan University Hospital, which has become a JCIA institution, recognized and very, very fastidious about timeouts and this kind of stuff. So the first thing when I reached there, I said, do you do checklists? Oh, yes. We've got this checklist, and there's always, in all the operating rooms,
it's up on the wall.
There's up on the wall in everyone, whether it's Bugando in Tanzania, you go in Zanzibar, you go to Medani in Sudan, they're all there. And then because I am the outreach neurosurgeon, I'm scrubbing, and I'm saying, can we do the timeout? And everyone's looking at each other and wondering, what is he talking about? So the point I'm making is, yes, the checklists have percolated into the systems, even in low and middle income countries where I go and operate in these rural areas. Is there some way that we can develop almost a league table of implementation? Because if they're not implementing them, and the administrators are very, very proudly stating, our hospital is doing checklists, and they will give you a very well enveloped, or nicely, this is what we use in our hospital. But when you actually go into the salt mine, it's not happening as consistently. It is happening in some. I mean, in Zanzibar, for example, it's happening like it's happening at the Aga Khan. But that's because we've ensured a different methodology there. But so a league table on how to do it, how to find out whether this is actually happening is my question.
Well, first of all, it seems to be the neurosurgery back row there. All the neurosurgeons are in the back row. Yes, so, when we went into South Carolina and launched, it was the policy that, all the hospitals were doing this. When you observe exactly what you see. And we've come to, the way we've come to observe whether the checklist is actually being used is when you stand and watch, does everybody speak with equal, do they stop? Do they actually run by the list? And does everybody speak with equal voice? It can't be a nurse in the corner running through the list and checking it off. If the surgeon speaks, the anesthesiologist speaks, the nurse speaks, then you know it's a different culture and that things have changed. One of the other tests is my secret weapon, our medical students, and I will ask them, did you get to introduce yourself in the operating room on your rotation? Because if you did, that's an indication that they actually are doing it and making it work. But the challenge is, and this is the third way of knowing, is when you've caught something that wasn't done on the checklist, what happens? And that is the moment when it's a change in values. Because the checklist, in order to actually use the checklist, you have to change your values. The values of the operating room are that we are here to serve the surgeon. That the autonomy of the surgeon is supposedly what a good operating room runs like. And the values of the checklist say, no, 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 no. This is not about the surgeon. This is about the patient. And does everybody understand, and have they all spoken to what the needs of the patient are and address them? So you go from the value being autonomy to one of humility, discipline, and genuine teamwork. And you, in order to drive that, when we went through in South Carolina, we asked for champions. So you needed a surgeon, nurse, and anesthesiologist, as well as a member of the executive team. And we would know, we did doing it all mostly remotely. So we would ask them to send us a digital picture of the team that would be implementing, with all of them, saying, I'm here to be on this team to implement this. That was, first of all, you lost 50% of the hospitals at that point. That was the hardest one for them to get, because you needed a surgeon champion to say, I'm going to make it work. Second is you first make whatever change in the checklist you need to make it work in your facility. And everybody has to make a change. It's different if you put the patient to sleep outside your operating theater than if they go to sleep in your operating theater. In Manila, all the nurses get recruited to the US and the UK. So they only have one nurse for every 4 operating theaters. So you have to make it run in a different way. So we ask them to send a copy of your checklist. Almost everybody's able to do that. Then the third part is test it in your own operating theater, make it smooth for yourself, and then take it to other people. Don't do the big bang. Don't try to say, everybody's going to do this today. Bring it step by step. And in order to go to the big bang, we ask them to go talk to every surgeon in particular, ideally everybody on the staff, but surgeon in particular, and ask them, would you help us? Because at least that stops them from going to war with you. And often it leads them to say, well, it's not just for me, it's for other people. And I will go along with it, and I might even help and participate. We found that process can get people to make the change. But now you're here, and that's the nitty-gritty of social change. That's the same way, when the polio campaign arrives in a village to do a polio rollout, and village members say, I'm not going to do it, you don't force it down their throats, so you have a complete backlash. You start with building confidence among those who have some championship and authority, and you have to do that basic blocking and tackling and move gradually to be able to make it successful. So doing that, combined with the incentive of it's an expectation at the government level as well, allows it to get somewhere. But they usually aren't hearing it matters to anybody above them, and they aren't also having support to make it happen and to go in place. No one showed them how to walk through that checklist. Told the nurse, you can tell the surgeon to stop until you've run through the checklist. And if they aren't looking at it, you can say, no, wait a minute. Let's go through it by looking at it. That's empowering people.
Thank you. We have to end quite punctually because you have an important dinner, as you told us.
And because it's Switzerland.
Yeah. I have a last question. You've seen, everyone here has read all your books. You've said, I'm sure there's another book in the making. You've said that I always write about things that confuse me. So what's confusing you right now?
A lot of these questions around implementation are the ones that have been, there are a lot of things that confuse me. What are we supposed to do about drug prices? It could go on and on. Why do we itch? But, but I think the ones that I'm particularly interested in that we're continuing to experiment with is, we certainly haven't cracked the nut on being able to make system level change. and being able to drive solutions. We just finished a randomized trial in North India with the WHO childbirth checklist, providing frontline support with hand-holding and coaching for the frontline caregivers and the managers, took them from that 0.6% hand washing and then 18 other areas, and got them to 70% performance from less than 40% performance along those key measures. So across 120 birth centers, largest trial done in childbirth, and we had marked improvement in practices, but no mortality reduction. And understanding how you begin to look at systems, recognize in advance how likely are we to be successful here, how unlikely, what's it going to require to unlock those steps along the way. That sense of who's ready to change, who's not ready to change, and how do I help there be more readiness. The other way of describing it is, why are there only 10 or 15% early adopters? How can we have more early adopters? Those are really interesting, confusing questions to me.
Thank you. Let's say thank you to this extraordinary man.
And thank you, Ilona.
I think we have a real public health hero here, and we'd like to thank you very much, Atul, for coming and speaking with us, and we hope to see you again.
And thank you.